given by Dr. Alpesh Doshi from UK. Dr. Alpesh is a consultant clinical embryologist and the co-founder of IVF London. He's also a co-founder and director of the Embryology and PGD Academy. He previously worked at the Center for Reproductive and Genetic Health in the leading capacity as a director of embryology for 19 years and was He has obtained a postgraduate degree in human reproductive biology from the prestigious Imperial College School of Medicine. Dr. Alpesh is a diplomate of the Royal College of Pathologists and also an European Society of Human Reproduction and Embryology certified senior embryologist. He has been an executive committee member of several international embryology societies and holds a very active interest in promoting education platforms through these professional bodies. He was among the first scientists to bring the egg and embryo freezing technology of vitrification to the UK in 2007. He's a world-renowned expert in the biopsy of human embryos for genetic testing. Welcome to Dr. Alpesh. He will be in live with us, and he will try to answer through his presentation to the intriguing question, is non-invasive PGT a hype or a hope? So the talk
that, oh, hello, can you hear?
You can share your screen now.
Oh, sorry, what happened? I don't know what happened. Yeah, can you see my screen now? Yeah.
Yes, yes, okay.
Perfect,
yes,
perfect.
okay.
All right, brilliant. So I will now show you some videos about how invasive testing is done, such as polar body biopsy and cleavage stage biopsy. So let's look at the video on the left-hand side is where we do the polar body biopsy. You can see we make a small channel in the zona pellucida using a laser. And we take out both the first and the second polar bodies. And of course, this technique is very antiquated now. Clinically, we do not perform any polar body biopsies per se, and everything has now moved towards Trifectaderm. The same can be said about the cleavage stage biopsy as well, and you can see that in the video on the right-hand side, that's a cleavage stage embryo, an 8-cell embryo. We breach the zona pellucida. And of course, the way we breach the zona pellucida is again, small bites of laser. And by making an opening, which is around 20 microns in diameter, we would aspirate 1 or 2 cells out of the embryo. And what we tend to do is by gentle aspiration, we insert the pipette, the biopsy pipette into the embryo and aspirate one of the cells out. We then moved towards Trifectaderm biopsy. And of course, at the moment, most of the PGTA that is done in the world is conducted using Trifectaderm biopsy. And the type of diagnosis that we have now replaced fluorescent in situ hybridization with is next generation sequencing, which is resulting in more reliable results when it comes to comprehensive chromosome screening. So here is a blastocyst, which is herniating quite nicely. And I'm sure you've already heard quite a few lectures already on Trifectaderm biopsy, but I tend to make my opening, my zona opening on day 3 of embryonic development with the Trifectaderm herniating quite nicely out of the opening. And then I use the laser to dissociate some cells, typically on day 5 or day 6 of embryonic development. And by applying 2 or 3 shots of laser, we can nicely peel off some of the Trifectaderm cells away from the embryo. And that's the small cluster of cells you can see in that video that has been taken. And the embryo is still quite nicely intact. The Trifectaderm and the cavity of the blastocelic cavity is still quite intact. The embryo hasn't really felt much happening at all. Of course, at the moment, with the limited time that is available to perform a diagnosis on Trifectaderm cells, the ideal scenario is to always cryopreserve the embryos after the biopsy. And then once the results are obtained, you can then conduct an FET cycle, potentially in the next cycle, or maybe after another clear cycle of the patient. Certainly, we know that this has now become the gold standard of any kind of invasive pre-implantation genetic testing, which is Trifectaderm biopsy combined with next-generation sequencing. We've seen that this has, certainly by vitrifying the embryos, this has given us very good survival rates of the embryos and coupled with very good pregnancy rates as well. So we now move to non-invasive pre-implantation genetic testing. And of course, the theory for the non-invasive PGT relies on genomic DNA being secreted into the culture media in which the embryo is growing. So typically, if you're using a single-step media, then you just need to have a very confined volume of drop in which the embryo is growing. And whilst the embryo is developing, it will release some cell-free DNA into the culture media, which can then be sampled at a certain stage of pre-implantation embryonic development. Typically, the studies that have been published so far have relied on sampling of the culture media between day 4 and day 5 of embryonic development. The aim of the whole testing is to sample some of this culture media and then amplify the DNA using next generation sequencing to look at the status of the embryo. The advantage of non-invasive PGT-A is that it is a non-invasive technique, as you know, and purely relies on spent culture media. And by using spent culture media, you're essentially not compromising any area of the embryo because this is waste products. So the validation model in the earlier years included seeing the embryos, of course, culturing the embryos till day 3, and then individualizing the culture from day 3 onwards. And typically, once the embryos have made it to the blastocyst, you do take a Trifectaderm biopsy to kind of validate the findings of the spent culture media or the non-invasive testing. You compare the results of the Trifectaderm biopsy with the results from the non-invasive testing. And you can also look at the remaining blastocysts to look for concordance. And of course, all this testing, whether that was Trifectaderm biopsy, whether that was spent culture media or the remaining embryo, was all done by next generation sequencing to look at the comprehensive chromosome testing. There have been many studies around the use of non-invasive PGT. And this work started as early as 2016. However, over the years and since then, all of these studies have tried to optimize one thing, which is concordance to the Trifectaderm biopsy. And of course, in the earlier days, in 2016, the concordance of non-invasive testing to invasive testing was very poor, and hence it was not clinically applicable. However, the recent studies, and mainly the studies that I'm going to be talking about, is the Huang et al. Paper and the Rubio et al. Paper, which was published in 2020, which is giving us much better concordance to Trifectaderm biopsy. And of course, these are multi-center trials as well, which hold a bit more water. Now you will see that that's quite a busy slide, but what I'm trying to show in that slide is that the various studies that have looked at non-invasive testing have all had a lot of variation in the methodologies, namely from the amplification method, whether they've used next generation sequencing or whether they've used array CGH, the type of culture media used, the size of the drops of culture media, and hence there has been very poor reproducibility and standardization of the whole process. So it can well be argued or criticized that there is very little comparison between all these studies simply because the techniques that have been used are very variable between study 1, study 2, and study 3. So it must be said that we need consistency in having a very unified approach when it comes to non-invasive PGT. And of course, we're still in the pursuit to finding that optimum protocol. What is the culture media we should be using? What is the drop size of culture media we should be using? When should we be sampling the spent culture media? Is it day 3? Is it day 2 to day 3? Is it day 3 to day 4? Is it day 4 to day 5? Or is it day 5 to day 6? So we need some level of consensus when it comes to non-invasive PGT. So the Huang et al. Study has been quite informative in terms of the various scenarios that have been seen in between invasive and non-invasive testing. One of the clear know-hows that we do have is that even with non-invasive testing, you can have a false negative and a false positive rate. And of course, this is also true for any kind of invasive testing as well. As much as false positives are something that you're cautious about, but it's the false negatives that can be lethal. So you really want to make sure that the false negative rate is very, very minimal. Of course, in this study performed by Huang et al., the false negative rate was 0. So it was very promising to suggest that we're not going to accidentally transfer an embryo that is affected. And of course, we all know that the various level of mosaicism rates that we still, in this day and age, even with Trifectaderm biopsy, the fact that we still see mosaicism is potentially to do with some of these mosaic cells, depending on where they sit within the whole Trifectaderm sphere. Some of these cells can occur within the outer layer of the Trifectaderm, and hence they can give some level of abnormal results or mosaic results. So we all know that mosaicism can exist, not necessarily uniformly throughout the embryo, but potentially depending on where you biopsy the embryo from as well. So going back to the Rubio study, this study was very nicely designed in the sense that it looked at the cell-free DNA released in the culture media, compared it to the Trifectaderm biopsy. It also compared the cell-free DNA to the inner cell mass. And ultimately, it also looked at the concordance of the Trifectaderm and the inner cell mass. It was quite nicely demonstrated in the study that the cell-free DNA was well concordant to both the Trifectaderm and the inner cell mass. And this study showed that similar levels of DNA or cell-free DNA were secreted or released both from the Trifectaderm cells and the inner cell mass cells. And hence it gave potentially a more accurate analysis of the ploidy level of the embryo rather than just sampling the Trifectaderm layer of the embryo. So one thing we know through this study is both the Trifectaderm and the inner cell mass both release cell-free DNA into the culture media. So the debate being that where do we stand on with PGT, or at least non-invasive PGT per se. We all know that in many countries, such as the USA, for example, PGS or PGTA is pretty much a standard modality of treatment. However, in the UK, our regulators have red zoned PGTA based on the evidence, and there needs to be more randomized controlled trials before it is listed as amber. So at the moment, we have to treat PGTA with caution and with the very clear notion that the evidence for its benefited use is still very limited. So it also must be said that although we're applying PGTA clinically day in, day out, Have they been enough clinically validated studies? And the answer is no, that there haven't been proper randomized control trials. It's not been certified by any regulatory authority in the world. There is still high level of false positives, which can potentially reduce live birth rates in theory. And of course, chromosomally abnormal embryos may also constitute the potential of self-correcting later on in development. We all know that confined placental mosaicism does exist, and yet you can get normal, healthy babies from them. Now, is confined placental mosaicism happening as early as blastocyst development? And some of these cells are within the trophectoderm. So are we over-assessing the validity of what we find in the trophectoderm and extrapolating that to what the baby is going to be when it comes to genetic abnormality? And the answer is that probably we are going to be getting some healthy live births from embryos that have been diagnosed as abnormal as well through PGTA. So the reliability of cell-free DNA is obviously, the theory suggests that when is DNA released into the media? We all know that two methods by which embryos do this is by programmed cell death called apoptosis or necrosis. Both these methods release cell-free DNA into the culture media. Of course, necrosis is to do with stresses that is encountered within the embryo, whether that is cryopreservation, whether that is stresses of the culture conditions. Apoptosis is more programmed cell death. And of course, apoptosis can also be influenced by culture conditions and pre-implantation and embryonic culture conditions during pre-implantation embryonic culture. Now, contamination of samples is also something which is of concern, because if you do have any kind of contamination, then that may not give a very adequate result. Normal embryos may shed much lower amounts of cell-free DNA. So is this a huge shift in the ability of getting results from normal embryos? Because we all know that healthy embryos may have a very low degree of apoptosis and necrosis. And because there is very little of their cells disintegrating and releasing DNA or cell-free DNA into the culture media, we may not effectively get an accurate result, simply because all the other algorithms when it comes to necrosis and apoptosis is very, very minimal in embryos which are euploid. So there needs to be consistency between culture media drops, the volume size of the drops between various clinics that are using cell-free DNA to assess ploidy. We also need to decide whether we're going to do group versus single culture. And of course, if we're going to be doing any kind of non-invasive PGT, we need to separate the embryos beyond a certain stage of embryonic development. It also has been seen that you can have variation in results between fresh and frozen embryos, because vitrified embryos may potentially, or vitrification and warming may impact on some of these cells not surviving. And if some of these cells are not surviving, that may result in necrosis and more negative factors being secreted into the culture media. So does this mean that we're getting an inaccurate result with non-invasive PGT, especially when these iatrogenic factors can impact on the results? So the first non-invasive PGTA baby was born in 2016. But again, when you look at the sensitivity and the specificity of even that study, you could see that, the concordance was around 80%, 84%. Now, when applied clinically, this is still considered to be a very low benchmark of concordance. So we all know that a lot of work has to be done when it comes to ensuring that there is concordance between non-invasive and invasive testing. And at the moment, the gold standard is invasive testing. It was also a concern that there was a high rate of false negatives seen in that study as well. And again, 12% is considered to be quite high when it comes to false negatives, and so is false positive rate. And again, the authors of that study attributed the false negative and false positive rates to mosaicism. So here is a table that shows that when you compare, or in the Rubio study, where it was a multi-center trial, you can see that even the concordance level is quite variable, from 72 to almost 86%. So there is considerable variation in the concordance level, as well as the specificity and sensitivity. However, it must be said that we're getting quite close to achieving a very linear and kind of narrow rate of false negatives when it comes to the use of non-invasive PGT. And at the moment, the concern is that if you're not getting concordance, is that because of any external contamination, such as cumulus cell contamination? And of course, if you're getting false negatives, that may well be because of cumulus cell contamination in the culture media. So how are we going to be improving this methodology going forward? Of course, there's a lot of work that needs to be done on validating the DNA amplification method that we should be using for this technology. What is the best time to collect the samples? We need consensus on that. As I said, is it going to be between day 2 and day 3 of development, day 3 to day 4, day 4 to day 5? And typically, most of the studies that have been done so far have looked at collecting the samples between day 4 and day 5. Is it worth collecting multiple samples, i.e. should we also be looking at between day 5 and day 6 to kind of validating the findings of results seen between day 3 and day 4, or day 4 and day 5? Should we be taking multiple samples? What is the volume we should be using for embryonic culture? Because ultimately, the amount of cell-free DNA that's going to be released in the culture media is going to be very limited. So is it better to really restrict the amount of culture media so that we can maximize the amount of cell-free DNA and potentially concentrate it in a very, very tiny amount of media? Now, my last slide is telling us that we should be using this technique and technology with caution. There is already a lawsuit in place. A clinic in Australia used non-invasive PGTA, and of course they're being sued at the moment because the lawyers of the couple said that she was misled as she was not told that the testing could produce a false positive result. So it is very important that we firstly ascertain the pros and cons of this technology. Secondly, we need to make our patients very aware of its limitations. And at the moment, the best concordance rate we have is 80 to 85%. So as much as this technique is showing us a lot of promise for the future, I feel that it is not quite ready for clinical application. But the future looks very bright, and every year we see more and more studies coming out which are showing us that the technique and the technology is certainly improving and the concordance is getting much better. So I think once we're at a 94 or 95% concordance level, I think we may well be able to say that we are able to use this technique clinically. So just some acknowledgements. Thank you so much to my colleagues who've helped me prepare this presentation. And thank you for your attention. And I'm happy to answer any questions that you have.
Thank you, Dr. I wonder if there's any question from the assistants. Yes, maybe we have a question here. Just to thank you and
Professor Ratvi?
We are arriving at the end of this session, and I would like to thank again
Okay. Professor Ratsby, can I ask?
Yes, please. Yes.
Thank you very much for your excellent talk. I have 2 questions. The first question is about PGTA practice. Is this practice regulated by the law in UK? First question. Second question is related to last paper of Norway Glacier of USA. The title of his paper is Testing for Aneuploidy A, Castle Built on the Sand. What's your opinions? Thank you very much.
So the first question, certainly PGTA is regulated by our regulators, the HFEA, but we have to apply it very sensibly as a clinical add-on, meaning we're not allowed to use it routinely, and our patients really need to be informed that it is potentially considered to be an experimental technique when it comes to, promising any kind of outcomes. So any kind of application of PGTA in the UK is done in the severest form as an experimental objective. The second question I did not understand.
Please, the major condition, indication of PGA in your lab.
Yeah, so we use it mainly for 2 things. Firstly, for repeated implantation failure and potentially repeated miscarriages. And of course, one can take the view that you may also want to use it for for advanced maternal age. So I would say that, mainly the application is for advanced maternal age, repeated miscarriage, and repeated implantation failure.
Okay, thank you.
Thank you, Dr. Doshi.
Second question?
Yes, Dr. Natek, your second question, please.
Yeah, I already asked
you
for
asked it. Okay.
Opinions of the last paper, because this practice is very
new,
controversial.
Yes, you mean the non-invasive.
Some author is for, some author is thought that it's a practice we do more for a less result.
Sorry, you mean the non-invasive PGT?
Yeah.
So my opinion on the clinical application of non-invasive PGT-A is that we are still a bit too early to apply this clinically. I think we need more clinical validation. We need more concordance of the data with what we call the gold standard technique, which is Trifectaderm Biopsy. So I take a lot of reservation before applying this technique clinically, and we are not yet performing this technique clinically in the UK at all.
Not for diagnosis, just for research.
Only for research.
Yeah, thank you.
Thank you, Dr. Doshi. Any other questions? If there's no more questions, I think we are going to finish this workshop. We are arriving at the end. So thank you again to the organization committee for the quality of the program. Thanks to all the speakers for the wonderful presentations, and thanks to the assistants for its interest. I wish you a nice evening and a good end of weekend. Bye-bye.
Thank you so much. Thank you.
Thank you very much.
Bye-bye.
Bye-bye.
Thank you.